Okay. So again, like just selected topics that we'll go over, half today, and then the other half we'll do tomorrow. Just a brief anatomy and physio, just to get us back into the world of GI. There's our anatomy. Remember, the GI system is just one long tube with a bunch of accessory organs that pop in along the way to dump in different things to digest or whatever. Function of the GI tract as we go through them. Digestion is the physical process that converts nutrients in the foods to stuff that we can absorb. Bigger macromolecules into smaller ones that we can then absorb into our body. That's what digestion actually is. We have digestive enzymes, which help speed the process along from exocrine glands. And mucus and epithelial cells as well. Secretion, we have to, large amount of volume of fluid are dumped into the GI tract. 2 liters of oral intake from fluid, and then 7 liters of secretions, whether it's saliva, gastric juices, bile, all that fun stuff. From this total of 9 liters that gets dumped into the GI system every day, only about 100 mLs actually winds up in the stool, unless you have a certain condition that will cause you to have diarrhea, then obviously it's a lot more. But for the most part, we can get most of it back. Motility, we have to move all of the chyme through the whole system, from the mouth through the anus. It's all smooth muscle coordination. I'm not going to go through all this stuff with smooth muscle depolarization. Remember, sphincters are the big one that allow movement. They close off areas, wall off, so that things won't pass until they're ready to go. Absorption, obviously the other part of the GI system is we have to not only break down these chemicals, but we have to have a way to absorb them as well. Remember, this is the first time we're getting these substances, so it's absorption. In the renal system, it's reabsorption. Either passive transport, diffusion, or active transport requires carriers. Defense. Our GI system is open to the environment. If you eat bad food, it's going to get into our system and cause issues. So ingested toxins, bacteria, viruses. So we have 2 mechanisms. One is immunologic defense, which is called GALT, G-A-L-T, gut-associated lymphoid tissue. These have Peyer's patches. Those will pop up when we get to certain diseases later on. And some mucosal immune cells, our lymphocytes are here as well. And we have non-immunologic defenses, secretions that can neutralize bacteria, kill it off, and whatnot. So basically, we want the bacteria to stay in the GI system and not get out. When it gets out, that's when we have issues. Regulation of fluid and electrolytes. Obviously, we have to make sure we don't lose a lot of volume of fluid from the GI system. So we want to make sure we absorb most of that back in. And excretion, obviously, any undigested food products, bacteria, some heavy metals are in the feces. So there you go. So regulation of digestion. We're going to review this again because a lot of the GI issues are regulation of digestion issues. Slow motility, things aren't moving fast enough through the system. When things slow down, you start getting some issues. We have 2 types of neural control. We have the intrinsic innervation. That is just the enteric nervous system itself. Intrinsic is from within. So this is that whole, like the gut brain. And then we have the extrinsic innervation. This is your parasympathetic and your sympathetic innervations. We have hormonal control and we have paracrine control of our digestion. So intrinsic is the enteric nervous system. We have 2 types. The myenteric, also known as the Auerbach's plexus. Myenteric, so what are we dealing with? Muscles. So this is the, muscularis externa, the muscle layer to provide that rostral or the haustral movement to get everything moving through the system. We also have the submucosal layer or plexus, known as the Meissner's plexus. This is really deep under that submucosal layer. This is where these neurons in this layer control what is being excreted into the GI system. Also, blood supply comes from this area as well. So blood and neurons are in this layer to help control the function of the excretion of the fluids or what else is going on. We do have some sensory neurons here as well. If you ever feel distended or bloated after eating something, it is those sensory neurons that sense that, stimulate or inhibit motility, secretions, absorption, and immune functions. Again, this is our little brain or the gut brain, where it can regulate itself without having to involve the central nervous system. Extrinsic innervation is also by the parasympathetic system. This is from the vagus nerve. Remember, the vagus nerve goes all the way from the brain, all the way down the body, all the way down to like that splenic flexure is where it kind of innervates the whole thing. So it's one long nerve that goes all the way from the brain all the way down. So that's one major one. It can stimulate or inhibit GI functions depending on what's going on. The input comes from the vagus nerve all the way down, and it synapses either in the Meissner's or the Auerbach's plexus, depending on what function it's going to do. But again, those two neural layers in the GI system is still under the effect of parasympathetic and sympathetic. Extrinsic innervation as well, carried by the sympathetic nerves. Remember, we have that side chain ganglia, so these will mostly be postganglionic. So that's why it's most post, because of the side chain ganglia that goes right after that. So we have acetylcholine here. Norepinephrine is the major postganglionic neurotransmitter. Sympathetic obviously makes sense, often inhibitory. What are we doing with sympathetic innervation? Fight or flight, running away. We don't want to have to stop and go to the bathroom to do that, so we shut everything off to the GI system with the sympathetic innervation, inhibit it, so that we can run away and do things. And again, from the brain to either the Meissner's or the Auerbach's plexi. It goes to both. And here's just a way of putting it all together in a graphical format, looking at how we have our sympathetic innervation, our parasympathetic innervation. Here are the sensory neurons giving some feedback to the brain. Do we have some distension, bloating, pain in the GI system? Pain is transferred via sympathetic nervous system inputs to the brain. It's from sympathetic. Hormonal control over a GI system. Some of them have dual function as a hormone and a neurotransmitter. They're found throughout the entire system. And we also have paracrine control, which is the side-by-side cells, where you secrete an enzyme and it affects the cells right next to you. That's the paracrine control. Examples are the histamine. Histamine is a paracrine control. It gets released in the GI system and affects the neighboring cells to help with GI, the acid secretion. Somatostatin is here as well, and serotonin. Okay, serotonin, that's why there's a link between what you eat and depression with serotonin, because the food that you're eating is affecting the serotonin in the gut, affecting your mood. Okay, when it comes to GI diseases, there's four main classes they're going to fall into. And most of you have fallen into one of these because it's a GI upset, and most everyone here has had GI upset at some point in their life. So abdominal pain or chest pain. Okay, obviously we include chest pain because if the abdominal cavity is hurting, things are pushing up, it can cause some problem in the chest, but for the most part, do they have pain in the abdomen? That's one classification of diseases, abdominal pain. The next one, are you having any problems eating? What's going in? Do you have a loss of appetite? Do you have any trouble swallowing your food? Is it painful? Are you not eating at all with anorexia? Where is the problem with ingestion of food? That's another one. The next one, Altered bowel movements. Do you ask your patient, do you have any diarrhea or constipation? That's another bowel disease classification. Is it a problem on the output? The last one is bleeding. Are they having any bleeding? Are they having any bleeding in the vomit when they have a vomiting episode? In the emesis, is there blood there? Is it bright red blood? On the back end, and the stool, is there bleeding going on? Is it bright red blood, which is usually a lower GI bleed, doesn't have time to go through the system, so it stays bright red blood? That's usually like a hemorrhoid or some sort of fissure in the anus cavity. Or is it dark black blood like melena, it's called? It has a very funky smell to it, but that blood has been going through the entire GI system. It's usually from the upper GI, like a bleeding ulcer in your stomach. That blood has to go through your entire GI system. It's going to be metabolized and broken down, and it turns black. So if you ever worked in a hospital and you've treated patients who've had GI bleeds and they've had melena, you'll know the smell and what I'm talking about. So those are the four main classes. So when you talk to a patient with a GI complaint, you ask them these questions. You have any abdominal pain, any problems eating, nausea, vomiting, constipation, diarrhea, or any bleeding? You've hit all four of those areas by asking those questions. So you can classify what is going on with your patient. So disease itself may be limited to just the GI tract, reflux esophagitis, diverticular disease, or manifestation of a systemic disorder where your inflammatory bowel diseases, Crohn's and ulcerative colitis, are from a systemic disorder that manifests in the GI tract. Maybe a systemic disease from a primary GI problem, vitamin deficiencies from malabsorption. We talked a few times about gastric bypass surgery. What is important to know about their gastric bypass surgery? Where the anastomosis was created. Do they have the terminal ileum or not? Why is that important? B12. So if you do surgery, you talk to a patient and they say, well, I had gastric bypass. Don't just say, well, it's like oh, I have my gallbladder out. Okay, you had it out. I don't care if it was laparoscopic or open, and it still got out. But in gastric bypass, because of the way that they do the cuts matters with metabolism, you have to know what kind do they have. Other examples, just as a side, next week we'll do thyroid, but again, if someone has a thyroidectomy, you want to find out why did you get that one out for certain diseases, and the other question is, like, do they have your parathyroid gland still in there? So there are certain surgeries, if they have them, you want to ask more questions about. Otherwise, if it's, I have a knee replacement, okay, whatever, hip replacement, whatever, gallbladder, appendix, okay, but with other surgeries, the less common ones, why? And can be complicated by dehydration. We know we lose a lot of volume of fluid in vomiting, diarrhea. They get dehydrated very fast, especially in age extremes, young and elderly. Sepsis, bleeding, shock, hypovolemia. We talk about hypovolemic shock. They will go into hypovolemic shock because of the severe dehydration from all this nausea, vomiting, and so forth. So let's talk about our first set of diseases. They're dealing with the esophagus, so acid reflux, GERD, and then the more severe types of that. So we're dealing with the esophagus. The key things that we're going to be talking the most about is right down there, this lower esophageal sphincter, or the junction, wherever it is. But basically, right down the bottom, the lower esophageal sphincter is what keeps all the acidic contents in the stomach. And that is what's being compromised in these patients. So basically, just a hollow tube. First third is striated muscle, so it's still voluntary motor. The striated muscle is motor. Then it gets to smooth muscle later on. Squamous epithelial cells. Why is that important? Why do I bring that up? Cancer changes, but remember, the squamous epithelium is not made for acidity. It's made just to transport food and get it down into the stomach. The stomach has cells and barriers, that mucosal barrier, to help prevent against the damage from the acid. The esophagus doesn't have those, which is why whenever acid gets up into the esophagus, it causes a burning sensation. They start doing this thing. They say, well, I have pain in my chest, and they're doing this. This is acid burn from reflux working up their chest. So again, lower esophageal sphincter prevents the contents from going up. So here is an endoscopy of the esophagus. And you can see this really clear difference between this type of tissue and the outer type of tissue. And this demarcation line is called the Z line. And it's very clear between. This is esophagus, this is stomach lining. This is made for acid, this is not made for acid. And you'll see some pictures in a little bit that show the damage that's done with this erosive gastritis or esophagitis and whatnot. So swallowing, we talked about that a little bit. Voluntary movement of the tongue, and then it kind of goes through an involuntary move from there. Remember, the swallowing cortex has a lot of these cranial nerves involved. You don't have to remember all the cranial nerves, but again, just remember in the back of your mind. When we get to the neuro and those stroke patients, you don't know what cranial nerves could potentially be damaged, so you keep them all NPO, no eating, until they can do proper screenings to make sure they can swallow things. Oral, pharyngeal, esophageal phase, I'm not going to go into much detail with all that stuff. We did it already in physio, just to review. Pressure changes along the esophagus, though. So it's normally low in the body of the esophagus, high at the upper esophageal sphincter and lower. So the tone, the pressure is highest at the top and the bottom to prevent contents from going up the mouth and obviously up in the esophagus. Any motility, disruptions in motility can be seen in patients who've had strokes or suffer from dementia. So they have problems with their own oral saliva. They can't swallow it appropriately. It goes down into the lungs, and it can cause aspiration pneumonia and a bunch of problems. This bottom part is really the key part here. Disordered lower esophageal tone is the problem. That lower esophageal sphincter loses its tone, so it becomes weaker. As it becomes weak, contents can start to creep up into the esophagus. And this just shows, again, the peristaltic waves that I go to move the food bolus down into the stomach so that we can start to digest it. So definitions, first one is dyspepsia, pain or discomfort in the upper abdomen, often recurrent, may be described as indigestion, gassiness, bloating, but it's dyspepsia. Okay, primary symptoms, upper abdominal pain, belching, nausea, vomiting. Early satiety, where they're eating and they feel full before they really are full. Heartburn is the painful burning feeling in the chest or the throat. Again, usually occurring after eating and may occur at night. Why would it occur at night? You're laying flat, acid can leak out. And worsens when lying down or bending over. Lying down for the same reason, bending over as you squeeze over, you're pushing all your stomach contents and it can squirt the acid back up just from the increased abdominal pressure from you bending over. We'll do it as well. So here's what happens with reflux esophagitis. Look at all these little sores that pop up from the erosion from the acidity that should not be in the esophagus. Do you still see that Z line anymore? That nice demarcation from the two different types of tissues? No, that gets obliterated and taken away. So this is reflux esophagitis. Okay. Maybe acute or chronic. This is just your common GERD. Persistent or repeated acid exposure. So you're constantly, injuring that tissue with this repeated acid. Mucosa is normally alkaline, does not tolerate highly acidic contents, and the stomach. So that's what's going on. Again, the tissue is not made for the acidity, So it starts to erode because of the acid coming up from the stomach. So predominant sign and symptom is just going to be heartburn, what they'll present with. Etiology, drugs that can lower the lower esophageal tone, morphine, dopamine, some calcium channel blockers can cause weakness of that lower esophageal sphincter. Food can also decrease the pressure of that sphincter. Chocolate, caffeine, spicy foods, onions. These are all things that will cause more acid reflux because this food will weaken the lower esophageal sphincter. And lifestyle modalities, here's smoking. Okay, smoking can also weaken the sphincter tone, causing GERD to occur in people that smoke. Other causes, pregnancy, alkaline injury. So we get reflux of pancreatic juices, gastric outlet obstruction, so nothing can leave the stomach. Hiatal hernia can contribute, and reflux of pepsin or bile. So pathogenesis, what's going on with acid reflux and GERD? So normally, the contracted LES prevents anything from going up. But when you start weakening that lower esophageal sphincter, you get increased frequency of transient relaxation, so it's just going to keep relaxing, increased stomach volume or pressure, increased production of stomach acid can all disrupt the normal mechanism. Reflux causes pain or the heartburn or epithelial damage that leads to your inflammation and erosion. Recurrent reflux leads to further reflux because the scarring that occurs with healing of the inflamed epithelium makes it less competent. So keep repeating, it's like a vicious cycle. It makes it worse, which causes more acid to come up, which causes further problems, which causes more acid to come up, and it keeps getting worse. Eventually, friable bleeding ulcers and exudates start to form, and then eventually you get some scar formation. But again, the sphincter function is compromised. That's the big problem with GERD. It's that lower esophageal sphincter doesn't work as well anymore. We went through some underlying causes of this weakened sphincter tone. As far as lifestyle modifications, you can tell your patients, if they say every time I drink coffee, I get heartburn afterwards. Well, maybe it's the caffeine that's causing the issue. Some complications of untreated GERD. One is called strictures in the distal esophagus. So we have damaged areas. If they start touching, when they heal, they can actually fuse together. So your esophagus normally should be one straight tube, starts to have issues where it starts to, constrict and cause some strictures. So eating will be a problem, won't be able to get past that. You just do a procedure where you do an endoscopy and you can pop those things and it opens the esophagus back up again. But progressive obstruction, as the strictures get more involved, more organized, they'll cause dysphagia. Initially, the solid food, they can't get the solid stuff down, but the liquid can still get past it, or thicker, like a milkshake, can get past it. But as it progresses and gets, the stricture gets more and more tight, then they start losing, even like, pudding or like applesauce will get stuck, and then eventually the liquid will get stuck like water and stuff. These are at risk for hemorrhage or perforation because we have an ulceration of the tissue now. So that area gets thinner and weaker and it can perforate. Hoarseness of the voice, as with this repeated acid reflux, if it gets up to your throat, it can affect your voice box, your larynx, and that will give you some hoarse voice due to the repeated acid reflux. Coughing, wheezing, and the worst one is obviously pneumonia, aspiration pneumonia from aspirated contents from the stomach. That's the worst case. Okay, this is called Barrett's esophagus. Barrett's esophagus is a form of cancer, and actually is a link between repeated untreated acid reflux can cause a cancer later on if there's like a mix of things that have to happen. But we get continued reflux of gastric contents can change your esophageal epithelium from normal squamous to a columnar interstitial metaplasia. So, again, the tissue in the esophagus is not made for the acid. The columnar is. It's got the protection there and mucosal layer. So what happens is over time, repeated damage causes the metaplasia, the changing of the cell type, which is obviously a risk. Now we're starting to invade some cancer cells into here. Now we start changing the cells. So goblet cells will start to appear. What do goblet cells secrete? Mucus. You don't really need a whole lot of that in the esophagus, but now goblet cells are starting to appear because goblet cells are made for all the high production of mucus, which is made and needed in the stomach. But now we're in the esophagus, which doesn't need it, but we're starting to get those cells to creep up. So goblet cells start to appear, and 2 to 5% with people with Barrett's will develop an adenocarcinoma in the esophagus. It's a malignant tumor of secretory cells. And obviously, smoking and alcohol abuse increase the risk. So you can see here, squamous mucosa, and there's your metaplasia and how it changes. There's your goblet cells starting to creep in to invade that tissue. And you can see here also squamous mucosa, and then there's our cardiac mucosa coming in from the stomach. And again, here's our normal, and then as we go down the cascade, cells get more disorganized. A lot of obviously dysplasia, metaplasia occurs, and eventually carcinoma in situ can develop. And you can see here again, here's our normal tissue. Nice Z line going around these demarcations. And now look over here. This is Barrett's esophagus. You see how the cell type has changed, all due to repeated acid erosion from the stomach. Okay, so that's Barrett's esophagus. Hiatal hernias. Hiatus means in Latin an opening. So we have an opening in our diaphragm where our esophagus can get through to get to our abdominal cavity so we can digest everything. A hiatal hernia is when part of the stomach pops up and it protrudes through that opening in the diaphragm. So a hiatal hernia, proximal stomach slides into the chest cavity through the opening in the diaphragm. This is what a hiatal hernia is. Okay, we have issues with our LES, so the competency in our lower esophageal sphincter is lost. There are different types. One is a sliding hiatal hernia, which is the most common, where the whole apparatus will slide up and down through the diaphragm and obviously contribute to reflux. So here's the different types. Here's a sliding hiatal hernia where that little thing will pop up. The next one is a really bad one, paraesophageal hiatus, because this stomach is popped up there. It won't come down naturally. You have to do surgery to repair that and pop the stomach back in and make that hiatal hernia, the opening, a little more tight so that the stomach doesn't pop up. So that's what a hiatal hernia is from a stomach perspective. Any questions about esophageal disorders? Basically just GERD, hiatal hernias, and Barrett's esophagus. Know the differences between the three. Okay. Moving on to some motility problems now. This is dealing with our stomach. So motility through the stomach, there's either we can go too fast or we can go too slow. So just review again our gastric secretions, cardia, the top part doesn't secrete anything. The corpus, which is the body of it, secretes the hydrochloric acid and the intrinsic factor. Chief cells, pepsinogen, that's for protein denaturing. And finally, the end of it is the pylorus. And we have the G cells that secrete gastrin at that point. Pure acid gastric juice is capable of digesting living tissue, so we have to have a protection barrier. So we have this autodigestion. How do we protect ourselves? We have the gastric mucosa, which helps protect against mechanical trauma and any chemical. And we have the epithelial barrier, the columnar epithelial cells. In the esophagus, it's the squamous, right? Here we have columnar. So after we eat, the regulation of gastric emptying is a combination of nerve input and whatnot. Increased tone in the proximal stomach, increase in strength of the antral contractions, opening the pylorus, and then inhibition of duodenal contractions, so we keep the food there. The rate of gastric emptying depends on chemical and the physical composition of the chyme that's entering the duodenum. Meaning, liquids will empty quickly, solids go slow. That's why if you drink water by itself, it'll go into your system pretty fast. But if you have just solid food, you got to break it down, digest it, and whatnot. That's why also like protein shakes help, because you don't have to worry about breaking down the protein. You just drink it, and it's already ready for digestion and absorption, so it's ready to go. Acid, fat, and hyperosmolar solutions slow gastric emptying. So high acid food, high fat food will slow the emptying, so the stomach has more time to break those things down. Acetylcholine is going to stimulate, and VIP and nitric oxide are inhibitory in intestinal feedback. So acetylcholine will stimulate the GI system, VIP and nitric oxide inhibit, and don't forget we have secretin, cholecystokinin there as well. So the first one is dumping syndrome. These are very common in surgical patients. Status post-surgical procedures is where you'll see a lot of this dumping syndrome. So partial gastrectomy, non-selective vagotomy. Remember, all the vagus nerve is responsible for a lot of things in that stomach, and if you cut it, nothing's going to stimulate the stomach to do stuff. Or gastric bypass. So basically, gastric dysmotility, everything goes through the system way too fast. So it's dumping, everything goes dumping right through. Nausea, vomiting, bloating, flushing, sweating, explosive diarrhea because it's getting out of the system very fast. Things are moving very, very fast. So dumping syndrome is a hypermotility. Things are moving way too fast. We don't have time to slow things down, especially through the large intestine, where we have time to get all that water reabsorption going on, or water absorption. You don't have the time for it, all that water that's in the large intestine is going to come out, and you get explosive diarrhea. So what is going on with dumping syndrome? We have a meal, we get rapid gastric emptying, so that food comes right out real fast. Couple things happen. Hyperosmolar jejunal chyme. Okay, hyperosmolar, so where's all the water going to go? Into the intestine or out of the intestine to the body? The contents of the chyme in the intestine are hyperosmolar. Which way is water going to want to go? Into the intestine. So this hyperosmolar chyme that comes into the duodenum, we got to balance that out. So we're going to dump a lot of water in there, again, dumping syndrome, to balance that out. So we get intraluminal fluid sequestration. The fluid starts to go into your intestines. What does that cause? Bloating and decreased blood volume, because all this fluid should be in the blood, but now it's being dumped out of the blood into the intestines. So you get some decreased blood volume, leading to hypotension. And hypotension will lead to tachycardia, to bring your cardiac output back up again. The bloating causes abdominal pain, which will then lead to diarrhea. This is how we get to the final symptoms from these dumping syndrome. We also have inappropriate gut hormone release, cholecystokinin, secretin, all those gut hormones we talked about, VIP and nitric oxide, causes issues where hypermotility occurs. We also have rapid glucose absorption. We don't have a nice constant supply of glucose being absorbed into our body naturally. We get it all dumped all at once. So we get crazy fluctuations in glucose, which lead to high amounts of insulin. And if you have a high amount from insulin, you get that sugar crash later on. And that's what the late hypoglycemia is talking about. So sugar management is very hard. Can you give oral medications to a patient with dumping syndrome? No. Probably not, because they're going to go through the system too fast. Absorption is going to be delayed, or if at anything at all. So mostly things need to go through IV for these patients, because your normal metabolism is not going to work very well. So this is dumping syndrome. Any questions about dumping syndrome? Usually it's going to be, again, post-surgical is who has these patients, who has these disease. Okay, yes? Is this usually just like self-limiting? Self-limiting? Yeah. Yes. Okay. So here's your little review for dumping syndrome. The next one, we did too fast. Now let's go too slow. Motility disorders where it's too slow. And this is called gastroparesis. Improper functioning of stomach muscles, delayed gastric emptying. So now we have an issue where the muscles don't work very well and the food just sits around for too long. Most common etiology, number one, idiopathic, but look at number two, diabetes. A lot of diabetic patients, when their sugar is not controlled. I emphasize that a lot, especially in this class. It's uncontrolled diseases that lead to a lot of these complications. Long-term uncontrolled diabetes will lead to, again, they all get autonomic dysfunction, right? I mention that a lot because a lot of autonomic dysfunction occurs with different diseases, but diabetes the most. They have neural problems. They're not going to move that food very fast. Could be vagus nerve dysfunction, either due to surgery or diabetes. And it can be a complication of diabetes, again, that autonomic neuropathy or dysfunction. Signs and symptoms of gastroparesis: nausea and vomiting, bloating and heartburn, early satiety. They get full faster. Why? What's already in the stomach still sitting there from breakfast? All your food's still sitting there. So you're going to get full faster. Lack of appetite, because you have food in your stomach just sitting there. You're not going to feel hungry. Weight loss, because you're not eating and you're not absorbing your foods very well. Yes?
Do both from gastroparesis and dumping syndrome, do they present with like low vitamin levels across the board?
I don't know if you would catch it that fast, but you're more worried about the other things first than the vitamins. Malnutrition, because they're not going to eat enough. They're not getting the calories in. They're not getting the protein in. They're going to have malnutrition. And obviously, blood sugar levels. If you're taking your medicine for your diabetes and the food's not going anywhere, you're taking this medicine and it's going to lower your sugar, which is going to be low already, making that worse. The other problem with gastroparesis is that sometimes all of a sudden the stomach will start working again, and then the food will start moving, and then you start getting these like pulses of like these high sugar levels, because all of a sudden it just comes out and gets moves through the system. So sugar levels are all wonky with gastroparesis as well. And then here's just looking at in a healthy one, but in gastroparesis, vagus nerve is damaged, pyloric sphincter is very tight, get some nausea and bloating, and the cycle will continue until you control their sugars. Certain medications can delay the rate of stomach emptying. Narcotic pain medications. People who are on like daily doses of pain meds will have constipation. Why? It slows down gastric motility. Those narcotic pain meds slow down gastric motility. Some of the newer drugs that are coming out for IBS-D, the irritable bowel syndrome diarrhea type, they're giving them, they figured out how to isolate the compound that causes the reduction in gastric motility from the pain meds without the addiction to the pain meds, without the resistance to it and whatnot. So it's just the side effect of the gastric motility, and we give it for people who have IBS-D, the diarrhea, to slow it down so you have normal bowel movements. Antidepressants can also slow bowel movements as well, so you don't go to the bathroom as much, and you can get constipation with that. So complications, one of the big ones is bacterial overgrowth from that food that sits there. This is called a bezoar, and basically the food turned like a rock in their stomach, and it just sat there, and eventually started getting bacteria and started growing, and obviously that's a complication from gastroparesis because nothing is moving. So a bezoar, solid, hardened mass of undigested food, and obviously issues, they're going to have complications with sugar, blood sugar. Those are the two major diseases when it comes to the stomach itself, dumping syndrome and gastroparesis. Let's take a break, come back at 10:55, and we'll move on. Okay, we'll continue on here. The last two things we're going to talk about is just peptic acid disease. So basically ulcers. Ulcers can be in the stomach and they can be in the duodenum. So the key thing for this one is to figure out where is the acid or where's the ulcer forming. Clues on their history will clue you into that, and we're going to go through all those as we go through this. So again, as you break down in your PD, the different quadrants and regions of the abdominal area, knowing where pain is located clues you into what organs are there and what issues they could be having. So when we come to this area, melena is that thick, black, tarry stools, bleeding in the upper GI tract, either esophagus, stomach, and the first part of the small intestine. Anything from there is considered an upper GI bleed. Hematochezia is bright red blood in the stool. Yes?
So, a baby's first bowel movement is called melena. Is it because, is it bloody or is it just black?
No, I think it's just whatever contents are in there just come out. I mean, they haven't eaten anything, so that they still are drinking an amniotic fluid. It's basically what it is.
Okay, so it's just a scrappy or not the...
Yep, it's not blood or anything. It's just the first one that comes out. But it's very thick and dark. What? What's it called?
She said it's called meconium.
Meconium, that's right. Meconium is the first one. But it's all amniotic fluid that's been eaten and swallowed while they're in the mother. That's what it's coming out. Yeah, when you first said it, I was like, I don't think that's the right word. But I couldn't remember what that one was. Hematochezia, bright red blood, again from the lower GI tract. Colon to the rectum is where you're going to have the hematochezia. And hematemesis is blood in the vomitus, usually from the stomach. So, peptic acid disease. This is dependent on this balancing act between the hostile factors, the gastric acid, H. pylori, NSAIDs, pepsin. These are all hostile factors in the GI tract, mainly in the stomach, and our protective factors, our prostaglandins, the mucus layer, the bicarbonate to neutralize the acid, blood flow to that mucosa. These are all things to help our defense in the stomach, in the GI mucosa. Excessive gastric secretion is only one factor in peptic ulcer disease. We also have to analyze the defense. Are we doing anything that alters our defense of acidity in the GI tract? So again, here's that little balancing act between healthy mucosa and ulcer formation. With ulcers, the hostile factors win. With healthy one, there's pretty much a good balance between the two. So with peptic acid disease, we have acute or chronic gastritis. This could also be erosive gastritis. Acute is common, it's benign, so acute gastritis, a little bit of an inflammation of the stomach. Chronic gastritis is associated with pernicious anemia because we aren't making the intrinsic factor. There's nothing to absorb in the terminal ileum because our stomach is having issues. Remember, the intrinsic factor is made in the stomach, we recycle it and we take up the B12 in the terminal ileum. Can be a risk factor for gastric carcinoma, and we can also have acute or chronic ulcer disease, and these can also develop from gastritis as well. So gastritis, gastric ulcer formation, either by reducing the quantity of prostaglandins, so we're reducing the defense or the hostile factors. The defense. We're reducing the prostaglandins, which is in the mucosal barrier to help protect against the acidity. If we reduce the prostaglandins, our defense is reduced. The hostile factors can take over and you get acid on the ulcer formation. Or weakening the cell barrier of the mucus and bicarbonate secreted. So we're not pumping out as much as well. So basically we're weakening the defense. And you can see on this picture here, this is the irritation from the gastritis. We still have our nice Z line here, but we get all this little ulcerations, little irritation going on. That is acute gastritis. Change your diet will be the biggest thing for that. So, here's an arrow link. Gastritis, atrophy of our gastric glands. So therefore, if we have atrophy of the glands, are we going to be producing enough acid? Nope. So not enough acid, or production of the protective mechanisms are going to be reduced as well. That's the more of the thing with this one. The defense mechanisms are reduced, so therefore the ulcer can kind of go rampant, the acidity, the defense is gone. Eventually it can lead to intestinal metaplasia, and that increases the risk of stomach cancer. So here's another link between acidity and stomach cancer. With chronic atrophic gastritis, we have autoantibodies. So another autoimmune disease causing gastritis. Inflammatory cell infiltration causes mucosal atrophy. And we lose our glands that secrete all the defensive stuff. The bicarb, prostaglandins, those are all going to be reduced. Serum levels of gastrin are increased. Gastrin goes up. What is gastrin going to do? Gastric acid secretion. So acid secretion goes up. Peptic acid disease is associated with H. pylori. So there's a bacterial infection causing the ulcer to form. Pernicious anemia. We lose our intrinsic factor even being made in the stomach, therefore less B12. Gastric adenocarcinoma and GI endocrine hyperplasia, which is a neuroendocrine tumor, are also complications of peptic acid disease. So here's your normal gastric mucosa, nice and pink and healthy, glistening with, has some, the glands are all working. Now over here, this is the chronic atrophic gastritis. Looks pale. All this irritation here. We kind of lose the ridges of the stomach, kind of all go away due to this chronic atrophic gastritis. So we're looking at the difference between the two. Again, picture-wise, you see the difference. So again, B12 due to intrinsic factor. So this is the important one right here. And we'll do one at a time. If it's a gastric ulcer, so the ulcer formed in the stomach, they're going to have chronic, mild gnawing or burning abdominal or chest pain. So this chronic pain, you're going to have pain in the abdominal area. Why? They get superficial or deep erosion of the GI mucosa. What layer has all the blood supply? Mucosal layer or the submucosal layer? Submucosal layer has the blood supply. So you can have an ulcer forming. If it's just in the mucosal layer, there's no blood there. But if that ulceration goes deeper and starts to invade the submucosal layer, that's where the blood supply is. That's when you get a bleeding ulcer because you got into the submucosal layer. So if your ulcer is bleeding, it's a deep ulcer because it got into the submucosal layer. This part is very important right here. Pain intensifies with food ingestion. Why is that? Right when you eat, acid starts to build up. It's going to hit that ulcer and cause a lot of pain. So right after they eat, they get a lot of pain. So what are they going to do? Not eat anymore because of the pain that it causes, and they cause weight loss. So a gastric ulcer, peptic ulcer disease of the gastric, pain immediately after eating, and potentially weight loss as well because they just don't want to eat because of the pain that it causes. So keep this in mind because when we talk about duodenal ulcers, it's going to be a little bit different. A duodenal ulcer, this is, again, the duodenum is that first little bit coming out of the stomach. That tissue is not made for acidity either. Remember, as soon as it hits that area, a lot of alkaline, what else is dumping into that area? What sphincter is there right in the duodenum? Sphincter of Oddi. And what two substances come out of that? Bile and your bicarb, your pancreatic enzymes from the pancreas coming along in there as well to neutralize all the acidity. But if you got too much acidity going into the area, it will cause ulceration to form. If it's a duodenal ulcer, the pain will not start until 1 to 3 hours after eating. Why? You got to get through the stomach first. Stomach takes a few hours to get through. So the pain with a duodenal ulcer will not hit for a few hours later because all the acidic contents and the chyme and all that stuff is still in the stomach. And once it's broken down enough, it's ready to be released. All that acidity goes into the duodenum a few hours later. You have an ulceration there. It hits all that, causes a lot of the pain. Yes?
So how long does it take for a patient to experience pain with the gastric ulcer?
It could happen within the first 30 minutes of eating. As soon as they're eating, the acid builds up and hits that area.
Okay, they don't get pain before eating,
Just
just after?
you gotta have the acidity has to be there. So the acidity won't come until you eat something where gas is released and all that stuff happens. Any questions? Okay. It can waken them up at night. If they had a late meal at night and they go to bed, pain can start there. Antacids or food intake provide relief with these patients. Why do you think food intake provides relief? What happens when you start eating? What happens to that pyloric sphincter? Closes because you got more food coming into the stomach which needs to be digested and broken down. So when you eat more food, that pyloric sphincter closes off, so the food stays in the stomach to be digested and broken down. If the pyloric sphincter shuts off, is any more acidic chyme going into the duodenum? Nope. That's why if they eat a little bit later on, the pain goes away because less acidic chyme leaves the stomach because the body's going to get ready to digest again. So because of that, these patients may gain weight. So a duodenal ulcer, overweight from eating to stop the burning. Gastric ulcers, skinny, may lose weight because they don't want to eat because of the pain that eating causes. You see the difference between the two. So when you start getting to your GI patients, it won't happen until next winter, but when they say, I get pain, when I eat, or pain after I eat, you got to find out when. Does it happen right after, or is it a few hours later that you get the pain? Important to know with regards to gastric ulcer versus a duodenal ulcer. Okay, the bottom just explains the different parts. So what causes peptic acid diseases? The big one is H. pylori. Here's your NSAIDs. We talked about NSAIDs, and it was a question on your exam because it dealt with the renal system and it dealt with musculoskeletal. They have bone pain, it hurts, let's give them NSAIDs. NSAIDs also can be destructive to the stomach lining itself. Why? Prostaglandins, right? We reduce the prostaglandins. That's what NSAIDs do to provide the pain relief and other things. But in the stomach, chronic NSAID use, ibuprofen, Aleve, those can cause ulcers to form. Alcohol abuse, shock, uremia, burn patients get stress ulcers, and any type of gastrinoma where they're just secreting gastrin unopposed. Whenever you have a tumor that secretes a substance, gastrinoma, insulinoma, prolactinoma, whatever it is, whenever we discuss these things, they do not exhibit the same negative feedback that normally would occur because they don't have the receptors that would turn off the production. All they know how to do is just turn on production and keep making more and more and more and more gastrin. They don't have the receptors to turn off gastric acid secretion. So they just keep pumping it out. So whenever you see stuff like that, just remember they don't have the receptors that would normally work to turn things off. Okay, moving on to H. pylori. This is the bug H. pylori. That's what it looks like. So corrosive agents secreted by the stomach play a key role in ulcer formation or acute erosive gastritis. The common themes again, excessive acid secretion or you're decreasing your mucosal defense. It's unclear which one started first, but we know that H. pylori can accelerate mucosal damage. So this picture is looking at what are the things that will impair mucosal barrier protection, blood supply, impaired mucus production, bile or pancreatic enzyme reflux. Here's your aspirin, your NSAIDs, and your H. pylori. H. pylori reduces your defenses so that the acidity can have contact with the tissue. That's all H. pylori does. It kind of buries a hole in the mucosal barrier so that they can get through. Here are the things that will increase gastric acid production, so the hostile factors. Increased number of parietal cells and chief cells that make the pepsin and the hydrochloric acid. Increased sensitivity to food and other stimuli like caffeine. Some people get heartburn as soon as they start drinking caffeine. It doesn't do anything for them. The coffee, they get it really bad. Excess vagal stimulation. That's why some people get a vagotomy. And decreased inhibition of gastric secretion. So if they had a gastrinoma, where they're just pumping out gastrin all the time, nothing is opposing it to turn it off. So again, those are all things that deal with peptic ulcer formation. Again, it's the seesaw. On one side, the hostile factors, one side is the defense. As long as the defense is good, you'll be fine. This is what a gastric ulcer looks like. Okay. This differs from erosive gastritis by the depth of the lesion. Gastric ulcers penetrate through the mucosa. Erosive gastritis is just the mucosal layer, that's it. But gastric ulcers can penetrate down to that mucosal layer. Most in the lesser curvature of the stomach. That's kind of where these ulcers like to hang out. What contributes to peptic acid disease? Motility defects is one of the big ones. And mucosal ischemia from the NSAID use, or acid erosion expressed tissue, death of tissue. So it doesn't like the acidic environment, it's going to die off. Duodenal ulcers are more common than gastric. So the duodenum will have more of the ulcers than the gastric will. May be a hereditary component here, so ask if anyone in their family also suffers from ulcers. Caused by altered mucosal responses, excess acid, and psychological stress. Could be due to H. pylori and less associated with your gastric adenocarcinoma. But again, these are just causes, underlying causes of what could be result in a duodenal ulcer. Here's a picture again looking at different forms. This is on the left is your duodenum, and then there on the right is your gastric ulcer. So you're not gonna have a picture to show you is this a duodenum or a gastric ulcer. Just again, just see what they look like. Okay, complications. I said before, if you're in the mucosal layer, that's where the blood supply is. And that is obviously a squirting ulcer that got into the vessel. And that's going to be bleeding. A bleeding ulcer, you will lose blood real fast these ways. They'll come in, they'll be anemic because all the blood is going into the intestine, GI system, not staying in the blood. But again, this is a bleeding ulcer. This was perforated, this will keep going until it stops. So acute or chronic GI bleeding, again, decrease in your hematocrit because those red blood cells are now going into the intestine and they're not staying in the blood. Hematemesis, hematochezia, melena, life-threatening perforation or obstruction. So if that ulcer goes deep enough, it will perforate the lining, and now those contents are going into the space in the abdominal cavity. Gastric outlet obstruction, just like what it sounds like, nothing's getting past it. And there's your bleeding ulcer. So here's your normal, healthy gastric mucosa. Now we get chronic gastritis. So remember, gastritis is just the mucosal layer. Now we have peptic ulceration, so peptic ulcer disease. And now look at what layers we go all the way down into. So there's another graphical representation showing you the differences between normal gastric mucosa, acute gastritis, versus a peptic ulcer, and how deep they go. Obviously, these will bleed. These will not bleed. So H. pylori, what is going on with H. pylori? Very common pathogen, half the world population, high in areas with poor sanitation and personal hygiene. Spread from person to person is likely fecal oral, so not washing hands. Water might be a reservoir for transmission. Endoscopic evidence, so anyone coming with a GI bleed is going to get an endoscopy regardless. See what's going on. You may see some gastritis or duodenitis. 50% of infected individuals will develop clinically significant ulcer. Some genetic, here's your environmental, smoking, and highly associated with the development of a gastric carcinoma. This is one of the only instances where a bacteria can lead to cancer. So what does H. pylori do? I'll give you the gist of it right here. Here is our gastric mucosal layer. That's our protective barrier. It has bicarb, prostaglandins, all that good stuff in that barrier. And then there is the epithelial cells of the stomach lining. Here is our H. pylori bacteria. It uses its flagellum to corkscrew and work its way through that barrier and work its way in. So you can see here, it's gotten in. The reason why it can survive is because what the bacteria does is it surrounds itself in urea, which kind of protects itself. So we'll get to that in a second. So H. pylori in that corkscrew fashion and gets through the gastric mucosal layer and gets to the epithelial cells of the gastric system and binds to that. It kind of attaches there. If it's in the duodenum, it will only attach to areas that have gastric epithelial cells already, because they have excess acid damage already. So H. pylori will only bind to gastric cells. It won't bind to the duodenal cells. So if you have a duodenal ulcer due to H. pylori, that means that you've had a lot of acid getting into, into that duodenum to cause the cell to change. It has to change first to a gastric type of cell to protect itself from the acidity all the time. But then that gastric cell is what will bind H. pylori. It can live in such a hostile environment because it produces urease, which converts the urea to ammonia. The ammonia buffers the hydrogen from the hydrochloric acid, and it forms ammonium hydroxide, which is alkaline. So it protects itself from all the acidity. So the H. pylori is surrounded by a cloud of alkaline material, and that's how the H. pylori can survive, because it protects itself by converting the urea to ammonium. Ammonium binds to the hydrogen, gets out, and around the bacteria protects it from the acidic environment of the stomach. That's how the H. pylori survives. So, damaging effects. One, this urease secreted by this H. pylori creates a very strong immune response. So we're going to get all these type of things going on in the area. The ammonium hydroxide that's produced from that conversion damages gastric epithelium as well, and also allows H. pylori to survive. We get endotoxins, lipase, proteases released by H. pylori, all go to degrade the gastric mucosa. We also have some cytotoxicity with the H. pylori, and you don't have to know those for the test, but there are other things that go on. So understand how the H. pylori burrows itself into the mucosal barrier, how it survives, and whatnot. Make sure you know what type of cell it's going to bind to. This is, again, looking at a broken down of the H. pylori. Here's the urease that helps make that cloud for it. There's the flagella, endotoxins that it can secrete, and obviously it has its effectors. What is it going to kind of inject into the cells? So that's H. pylori. And then here's another picture for you to summary. Another type of cancer with H. pylori is this MALT, which is mucosa-associated lymph tissue. We talked briefly a little bit about GALT, the gastric one, but this is mucosal. You can see here, 80% will be fine. Just some simple gastritis. 15 to 20% will have some atrophic gastritis or an ulcer. Less than 1% will have the cancer, which is the MALT lymphoma. So the majority of people with H. pylori, maybe a little bit of gastritis, but they'll be fine. 15 to 20% will have an active infection, ulceration. Less than 1% will have the cancer form. NSAIDs. Okay. What would cause someone with daily use of NSAIDs to leading to ulcer formation? One is advanced age. So the older you are, why would NSAIDs lead to gastritis the older you are? What happens to the metabolism of these NSAIDs as you get older? It goes down. So what happens to the concentration of the drug in the body? Increases. So you have more of an effect on those prostaglandins. History of previous ulcer disease, use of steroids or anticoagulants, high doses of NSAIDs, so there's a limit to how much you're able to take in a day, and any other systemic disorders can lead to these issues as well. So this is what happens to your stomach with chronic NSAID use in the ulceration formation. Again, NSAIDs is going to reduce the protective barrier, your defense mechanisms. So NSAIDs irritate mucosal injury topically by diminishing the hydrophobicity of gastric mucosa. Again, just talking about what's it going to repel. Endogenous gastric acid and pepsin may injure the surface epithelium. Systemic effects of NSAIDs obviously play a predominant role. All this COX pathway, it's all there. Although NSAIDs can inhibit both pathways, only the gene for the COX-2 contains the corticosteroid responsive element. So only COX-2 will be affected by the steroids. Okay, so it's all this COX-1 and 2 pathways that lead to reduction of prostaglandins, which leads to the reduction of the barrier. So it's the COX-2 pathway that gives you the prostaglandins on one side. COX-1 gives you prostaglandins on the other side. One is for gastric mucosa, the other one for pain, fever, and inflammation. Gastritis in patients on NSAID therapy, underlying H. pylori than other drug use. So if they get an ulcer, it's usually just due to H. pylori in addition to. NSAIDs may cause ulcers independent of H. pylori if they start really messing up with prostaglandin synthesis. The changes that NSAIDs make may cause issues with pepsin and very toxic to unprotected mucosa. So the pepsin, when you have these openings in the barriers, the pepsin can get to that area and it's toxic to the cells. And there's a summary slide for that. And we are done for today.